Good morning, everybody, and welcome to the parallel session of Charter Day in Otolaryngology. We're delighted to welcome you to the session on Pediatric Otolaryngology this morning, and we've got a stellar cast from around the world. But a lot of you will recognise faces and names from either previously training here or visiting here or by virtue of just being Irish. So with that, I think we'll start with our first speaker. I'm Mary Bresnihan, and I'm one of the ENT surgeons at Sligo University Hospital, and Professor Paul O'Neill will be co-chairing with me. So Paul, do you want to introduce our first speaker?
Thank you, Mary. Good morning, ladies and gentlemen, and welcome to this Pediatric Otolaryngology session. I'm delighted to welcome our first speaker, who's Dr. David Leonard, well known to all of us, Associate Professor of Otolaryngology at Washington University School of Medicine and attending otolaryngologist at St. Louis Children's Hospital. David is also Vice Chair and Chief of the Division of Pediatric Otolaryngology at Washington University. We're delighted to welcome him this morning. Look forward to his talk. Thank you, David.
Thank you, Paul. I'll just start sharing my screen. So thanks, Paul. And, you know, it really is an honor to be speaking to you today. And I'd like to thank the organizing committee for inviting me. It is appallingly early here in St. Louis, but given the enormous impact that Dr. McGill has had on my career, I felt that getting up early was the least that I could do. I've no disclosures. So this morning, I'd like to speak to you about the embryology of the airway and how that relates to the congenital airway pathology that we see and manage. And then I'd like to cite the example of a patient that was referred to us at St. Louis Children's Hospital to illustrate that point. It seems clear that a good understanding of normal development of the airway is fundamental to understanding the pathology that occurs when it goes wrong. The larynx and trachea are largely developed by the 12th week of gestation. The process starts at the 3rd or 4th week, when the foregut begins to lengthen to accommodate the enlarging hepatic and cardiac primordia, and a groove develops in the ventral surface of the developing primitive pharynx. This is the laryngotracheal sulcus. And then over the following 7 to 10 days, this groove deepens and elongates with the lengthening foregut. As it lengthens, the mesenchyme invaginates and develops invaginations develop at the posterior lateral wall of the groove. These are the tracheoesophageal folds which grow towards each other, fusing to separate the respiratory primordium from the primitive pharynx. And as the respiratory diverticulum elongates, these fused folds ultimately form the tracheoesophageal septum, the common wall between the trachea and the esophagus. When the formation of the tracheoesophageal septum fails, you end up with a communication between the respiratory and upper digestive tracts. This can present in infancy as a tracheoesophageal fistula, many of which are diagnosed prenatally, but these typically fall outside of our remit, unless they're recurrent, in which case we sometimes have a role to play. In pediatric otolaryngology, failed formation of the tracheoesophageal septum presents as a laryngeal cleft. These defects in the common party wall between the larynx and the trachea and the esophagus have an incidence of between about 1 in 10,000 and 1 in 20,000. And they were originally classified by Benjamin and Inglis based on the depth of penetration of the cleft, with a type 1 cleft extending to the vocal cords, a type 2 cleft extending partially through the cricoid cartilage, type 3 fully through the cricoid cartilage, but not through the thoracic inlet, and a type 4 cleft through the thoracic inlet. While higher grade clefts, types 3 and 4, typically present in early infancy due to intractable aspiration or feeding difficulties, and are often associated with other congenital abnormalities, type 1 and some type 2 clefts can often present with more subtle symptoms much later in life. Recurrent croup, recurring lower respiratory tract infections, chronic cough. In recent years, the type 1 cleft has become a more functional diagnosis characterized by findings of a deep intrarytenoid groove and evidence of aspiration. And this has led to an increase in the reported incidence of laryngeal clefts. It's also expanded the patient population that we manage with this diagnosis considerably. So while the respiratory primordium elongates below, above the level of the future glottis, a cushion of tissue grows for the ventral surface of the pharynx and largely obliterates the upper respiratory lumen. This is the epithelial lamina, and in week 5 of gestation, 3 mesenchymal swellings develop on its superior surface, which ultimately develop into the epiglottis and arytenoids. The laryngeal cecum is the depression bounded by these swellings, and over the course of the next 14 days, it descends along the ventral surface of the epithelial lamina until it reaches the level of the glottis. As it lengthens, it enlarges laterally to create the spaces that will become the laryngeal ventricles. Over weeks 8 to 10, the epithelial lamina involutes and the airway recanalizes from a posterior superior direction anterior-inferiorly. And failure either of the full development of the laryngeal cecum or of recanalization of the epithelial lamina leads to either laryngeal atresia or formation of a glottic web. And both of these can cause congenital high airway obstruction syndrome, which I imagine Ms. Mahana is going to be discussing later. Laryngeal atresia, which results due to the failed or incomplete development of the laryngeal cecum, was classified by Smith and Bain and is based on the degree of recanalization. Type 1 atresia results from arrested recanalization during the 7th week of embryologic development and results in a shallow trough at the side of the laryngeal cecum. Type 2 is due to arrest during week 7 or 8 and results in a partially formed laryngeal vestibule. Type 3 is the most common, with arrest occurring after week 9 of fetal development and is essentially indistinguishable from the laryngeal web. Pathologically, laryngeal webs are thought to be due to incomplete recanalization of the epithelial lamina following the full development of the laryngeal cecum. But as you can see, the distinction between a type 3 atresia and a type 4 web may be notional. Moving on, the cricoid cartilage appears to fuse from 2 lateral cartilaginous centers, which unite at the midline. And by the 7th week of development, these divine a narrow teardrop-shaped subglottic lumen, which becomes rapidly occluded by proliferating mucous membrane cells. By the time the laryngeal spaces above are fully defined in week 10, the cricoid has expanded to accommodate a smooth mucous membrane lining. Failure of the cartilage ring to expand and remodel fully, or ongoing proliferation of the soft tissue within the lumen, can both result in subglottic stenosis. And from a management point of view, distinguishing one from the other is crucial. While there may be some hope of managing a soft tissue stenosis endoscopically, the cartilaginous stenosis is much more likely to require open reconstruction. So that's a very quick overview of early embryology of the airway and how it relates to some of the congenital pathology. I've eliminated many of the smaller details, and we haven't touched on the vascular and neuromuscular anatomy. I would, however, like to move on to a case that illustrates some of the findings we've covered. The patient was a term newborn with a history of polyhydramnios and dextrocardia, which was diagnosed shortly after delivery, who was referred to us from another institution at 4 days of age for management of a suspected laryngeal cleft. He had had feeding difficulties from postnatally and concerns for aspiration, and a contrast swallow demonstrated contrast throughout the airway, which you can see stippled throughout this chest x-ray, particularly on the right. On arrival, he was taking nothing orally, but otherwise was doing quite well. He was saturating while on room air without any support. And because of his dextrocardia, he had an extensive cardiac workup. But once the neonatologists were happy he was stable, we took him to the operating theater for an airway evaluation. And this is the moment of truth when this video works or not. So as you can see from the video, there's a defect in the common party wall, which extends starting at the intrarytenoid groove through the cricoid and into within 1 centimeter of the carina. And although this is not a great picture, since it's a screen grab from the video, you can see the carina in the distance anteriorly, and then the esophagus posteriorly with the blue nasogastric tube and the lumen, and the rudimentary tracheoesophageal septum forming a bridge between distally. As I mentioned, the child was surprisingly stable given the extent of the cleft and a large amount of contrast in his lungs, but we took advantage of that and let him grow for several weeks before attempting to perform a repair. There isn't a great deal of literature out there on repair of type 4 laryngeal clefts. They're rare, and many of the patients have other congenital abnormalities that are incompatible with life. But there is guidance on management and technique. And following that, and after a fair bit of research, we elected to perform the case on ECMO to allow us to manipulate the airway more easily. One of the long-term problems that we see frequently with laryngeal clefts is severe tracheomalacia. And in the hopes of preserving as much of this trachea's structural integrity as possible, I'd hoped to repair the cleft without incising the trachea anteriorly and further weakening it. The technique that we attempted starts by separating the larynx from the trachea and elevating the trachea from the underlying esophagus. And obviously, working up there by the cricoid, there's a lot of risk to the laryngeal nerves using this technique. So our first step was to try and expose the nerves and find them to protect them. The recurrence are not easy to find in a 1-month-old child, and we failed. And so we elected to abandon this technique and went through a more standard anterior approach using a laryngeal fissure and incising the anterior tracheal wall to expose the cleft. Once the cleft was exposed, we did a four-layer closure, interposing tibialis fascia and costal cartilage between the repaired esophagus and trachea. The repaired cleft did heal extremely well. We got really nice mucosalization. We had a nice lumen, but despite that, the patient did have a very rocky postoperative course, partially due to bad tracheomalacia. We had held off at the time of surgery performing a tracheostomy, both to allow the anterior tracheal wall to heal, and also in an ultimately vain hope that we might be able to eventually extubate him. His airway was very challenging to manage with an endotracheal tube. He had copious secretions, which you can see down here at the carina. And because of his tracheomalacia, we had to position his endotracheal tube very distal, just above the carina. This led to difficulties with main stemming and obstruction and difficulties with ventilation. He dropped his lung a couple of times and really gave the neonatologist fits. Ultimately, we placed a tracheostomy tube about 3 weeks post-repair, and he had a G-tube placed by our colleagues in pediatric surgery. And then following a protracted NICU stay, he ultimately went home to his family. And despite his rocky start, he's done exceptionally well. This is him a couple of weeks ago. He is still ventilator dependent, primarily due to his tracheomalacia. He's taking all of his calories by mouth, but he does still have a G-tube, which he uses occasionally for free water. He vocalizes around his tracheostomy tube and is developing age-appropriate language skills. And otherwise, he's meeting his developmental milestones. And he's, a real example of the fact that pediatric airway surgery, when it goes well, can be extremely gratifying. So there's no doubt that understanding the embryology of airway formation gives us a better understanding of the pathology when it presents postnatally. Where this really has the potential to get exciting is when we start to think about prenatal intervention, not just exit procedures for congenital high airway obstruction syndrome, but potentially fetal surgery to correct these defects in utero. That's where the future lies, and that's where we need to improve our understanding of these patients' pathologies and our surgical techniques to address them. And that's all I have for you today. And so again, I want to thank the organizing committee to invite me to speak today and to convey my lifelong appreciation and respect for Dr. McGill. It really has been my pleasure. Thank you very much.
Thank you very much, David. That was a wonderful talk, a great overview, and lovely to see the results at the end. We're going to leave, we'll have 15 minutes at the end of the session for panel question and answers. So if any of the delegates have questions, please put them up on either the live Q&A session or the discussion forum on the live session portal, please. So with that, we'll move on to our next speaker, and I'd like to welcome Ms. Mira de Kruijf, a consultant paediatric otolaryngologist and deputy clinical director for surgery and theatres from the Royal Manchester Children's Hospital. Thanks, Mira.
Thanks a million, Mary. Thanks everyone for having me. And thank you, Dave, for an absolutely wonderful talk. I was absolutely delighted to be invited to speak today alongside so many amazing people. I've sort of made a cross from my own back by picking a big title for a 15-minute talk. So if everyone's all right, I'll just crack on with the talk, if that's okay. And this is the title. So just by way of introduction, children with complex neurodisability, they often have multi-level, multifactorial airway issues, which unsurprisingly play a major role in both the quality of life of these children and their life expectancy. So if you look at epidemiological data from the US, which is where data is is best captured within this patient population, just over 3/4 of deaths in children with neurodisability were as a result of lower respiratory tract infections. And if you look at large community surveys of children and adults with neurodisability, they would seem to suggest that just over half of deaths were as a direct consequence of respiratory complications. So I suppose the purpose of this introductory slide is just to set the stage to say that while this is a common clinical experience and it's well recognized in practice, there's actually a relative paucity and it's poorly represented in the literature. And there aren't many guidelines, clear guidelines to direct the practicing physician. So for the purposes of today's talk, I've sort of structured it such that I discuss each level of obstruction. And I've sort of structured it from the top to the bottom, if that makes sense. So the first level of obstruction is sleep disordered breathing. So in this context, the upper airway, it's a pliant tube that's made up of muscle and a variety of other sort of soft tissue. And during wakefulness, neural inputs into the small muscle groups of the pharynx, they maintain muscle tone and airway patency. And invariably, when we fall asleep, there is an element of muscle relaxation and a consequent increase in resistance to airflow. Now, normally, compensatory mechanisms exist such that this doesn't have any sequela. But in individuals who have either anatomic issues or neurologic issues, or indeed both, they can experience cyclical episodes of either partial or complete airway obstruction overnight. So just in terms of anatomic factors, you have things like adenotonsillar hypertrophy, tongue-based collapse, and laryngomalacia. And neurologic factors include things like hypotonicity, abnormal neural regulation, and abnormal crosstalk between dilating muscles and the airway walls. So just as an example, children with Chiari have both central and obstructive events, central due to maldevelopment of the respiratory center, and obstructive events because of their bulbar palsies. Children who have muscular dystrophies, with the exception maybe of Duchenne's muscular dystrophy, have a reduced central respiratory drive. And the bulbar palsies associated with motor neuron disease can cause hypoventilation and hypoxemia. And all of these then lead to sleep disordered breathing. So this is a diagram that I made in a most OCD fashion, but that's what I am, I'm sorry. Just to show that at multiple points during their sleep, these children are predisposed to upper airway collapse. So they have decreased pharyngeal tonicity for all the reasons we've discussed previously. This then predisposes them to upper airway collapse, which may be partial or complete and cyclical over the course of the night. They then have apneic episodes or hypopneic episodes, and it's important to remember that these can be both peripheral/obstructive or central. They are then predisposed to hypoxia and hypocapnia in children who have already some degree of neurological impairment. And then for multiple reasons that we'll discuss a little bit down the line, they may have an impaired ability to raise a respiratory effort to correct this. So at multiple points along the sleep cycle, they have issues with their sleep and airway obstruction. Right. It's just a quick cap to say overnight oximetry, which is sometimes called sleep studies. They're really quite a blunt instrument, I think. And they're really only useful if they're positive. So they have a poor negative predictive value, and they miss up to 47% of children with mild to moderate sleep disturbance. And actually studies have quite clearly shown that there's quite significant night-to-night variance with overnight oximetry. So it's not a massively useful tool, and the diagnosis of sleep disorder in children, all children, is really a clinical one. In terms of management, I suppose it's important not to turn your back on the easy wins. So things like adenotonsillar hypertrophy, even if the ads and tonsils aren't massive, it's important to remember that what you're trying to do is remove one level of airway obstruction in children who have quite often got multiple levels of airway issues. So it's not to make them, well, it's not to cure them, it's to try and make them better and to take a child who is not coping to a position where they might be able to cope better. So the next level of airway issue would be tongue base collapse. So it's just to show a video here. So I've got a suspension laryngoscope in my left hand and a Hopkins rod in the right. And you can see from the video, if it plays, yes it does, that as I release the suspension laryngoscope, you can see the tongue base prolapsing onto the epiglottis, and that causes an element of upper airway obstruction. And actually what you can do there is you can coblate. So we do a coblation reduction tongue base. So you sort of coblate essentially a cup into the tongue base for the epiglottis to sit into. And that relieves that level of tongue base obstruction. It's actually quite an easily done procedure. We tend to admit them overnight and they go home the next day, and pain doesn't seem to be a massive feature with coblation. So that's how we manage those. In terms of laryngomalacia, we know that it is commonest cause of stridor in the infant and the commonest benign condition affecting the pediatric larynx. And this is a video that demonstrates sort of classic laryngomalacia. So you can see the sort of tightly curled epiglottis, these tight area-epiglottic folds, so no sort of lateral channels, redundant mucosa over the arytenoids, all of which collapse into the supraglottis or the laryngeal inlet, interrupting laminar airflow. And that turbulence causes sound, and that sound is a stridor. And that's sort of classical laryngomalacia. And for that, you can do an aryepiglotoplasty, which is where you divide these aryepiglottic folds and trim the redundant mucosa over the arytenoids to sort of create lateral channels and prevent that sort of supraglottic collapse. But in children with neurodisability, they have a slightly different sort of picture. They have what I call neurogenic laryngomalacia, which is also supraglottic collapse, as you can see on this video, but it's not so much. If I go back on the video just to show you, you can see they actually have lateral channels, but you have more sort of patular, sort of flaccid supraglottis. And in these children, a classic aryepiglotoplasty doesn't necessarily help in any significant shape or form. So I suppose the next level of obstruction is an ineffective cough and secretion clearance. So the first thing to say, I suppose, is that a cough requires synchrony. So you have sort of forceful contraction of the intercostal and abdominal muscles against a closed glottis. And that synchrony can be lost in children with neurodisability. They also tend to have a reduced sensitivity to cough, and we're not sure why. One of the postulated theories is that they have reduced or desensitization, I suppose, from their upper airway irritant receptors, potentially due to chronic aspiration. Positioning is also really important in these children. So for example, if they're in a chair, it's really important that their trunk is well supported in the chair, the trunk and neck, because obviously if you're slumped over and your neck is flexed, it's very difficult to mount an effective cough. From a more distal perspective, they may have underlying tracheobronchomalacia, bronchiectasis and parenchymal lung damage, which affects secretion clearance. And then it's also important to recognize that there may be delayed recognition of aspiration or acute infection in these children as well, for a number of reasons. This is just a video demonstrating tracheomalacia. So it's normal supraglottis, normal chords, and essentially a normal subglottis and proximal trachea. But when you get into the distal trachea, you can see from the video that there's complete apposition between the anterior tracheal wall and the trachealis. And you can see immediately why these children would be prone to developing recurrent lower respiratory tract infections. And then because of the sort of inspissated trapped secretions beyond this malasic segment, they'll run a protracted course for resolution. So just in terms of how we manage these, non-invasive treatments to consider would be things like chest physiotherapy, the cough assist, but again, this needs a compliant child. You can functionally splint the airway with high flow oxygen or either CPAP or BiPAP if the child is tolerant of it. And also consideration of prophylactic antibiotics, for example, over the winter period. Surgical options, I suppose, are dependent upon causation. So in our practice, if a child has tracheomalacia, we often get a contrast CT thorax to ensure that there is no extrinsic vascular compression. And often, to be fair, there isn't. And the commonest finding would be an aberrant normal caliber innominate that sort of runs across the anterior surface of the trachea. But if there is evidence of extrinsic compression, then it's worth getting the opinion of cardiothoracics to see whether or not they'd consider a PECSI. And it's important to do this before you offer a tracheostomy, because they don't like doing a PECSI with an open mediastinum for obvious reasons. And if, for example, a child has a long segment tracheomalacia, then a tracheostomy may be indicated. And then just a quick word on recurrent aspiration. So again, swallowing is a really complex process that involves a series of sort of intricately timed maneuvers. And again, it's not surprising that in children with neurodisability, they can lose this synchrony. So although the exact incidence isn't known, video fluoroscopy studies would suggest that in children with cerebral palsy, just over a quarter of them aspirate. And that's due to multi-level, multifactorial reasons. So they have impaired bolus formation at the oral stage of their swallow. They have impaired glottic closure. They may have impaired esophageal peristalsis. And then they also have impairment of sort of turn taking between swallowing and breathing. And for all of these reasons, they're at increased risk of aspiration. But it's also important to recognize that they don't just aspirate on food. So in between feeding, they often aspirate on their oral and upper airway secretions because they have reduced protective mechanisms. For example, the same impaired glottic closure and impaired cough. And then again, for reasons that are poorly understood and fairly little researched, gastroesophageal reflux tends to run quite a protracted and severe course in children with neurodisability. And that'll be due partly, of course, to tone. But then on top of refluxing food and oral and upper airway secretions, they're aspirating on their refluxate. And actually the sum consequence of this is that they have sort of chronic low-grade airway inflammation that then results in bronchiectasis and parenchymal lung damage. And of course, once you have bronchiectasis and parenchymal lung damage, you have impaired secretion clearance. And they get this, which is sort of a vicious self-perpetuating cycle. And once you have this, you get a restrictive pulmonary picture, which then compounds the obstructive pulmonary picture they have from the upper airway for all the reasons that we just discussed before. And that just brings me finally on to tracheostomies. So in terms of the indications for tracheostomies in children with neurodisability, these include things like multi-level upper airway obstruction, neurologic and neuromuscular causes, and severe tracheomalacia. It's really important that these are multidisciplinary discussions and very closely involve the parent or the carer of these children, because while they will solve some problems, they will create other problems. So for example, you have an open airway, and in these children who, as we've already discussed, are prone to lower respiratory tract infections, this can exacerbate that condition. It also significantly increases the burden of care for parents and carers. But really the overarching issue, if you're going to decide on a tracheostomy, is what difference it will make to the quality of life of both the child and the parent carer at this stage in their clinical progression. So I suppose in conclusion, it's just to remember that this is a progressive problem. It's a multi-level, multifactorial progressive problem. And it's really important to manage the airway actively and to journey with both the patient and their parent carers, engaging with them, taking into consideration, I suppose, their concerns, their anxieties over their child and what their expectations are, because it's very difficult to join a conversation at the latter stages of this child when you haven't journeyed with them through this progression, to then jib in and say they do or do not need a tracheostomy. Don't turn your back on the easy wins. As I said, things like adenotonsillectomy are not to be scoffed at because the alternatives are quite significant. And then finally to say not to avoid a tracheostomy when it's clearly necessary, because if timed appropriately, it can result in a significant improvement in the quality of life of both these children and their parents or carers. And that's me done, I think, with 1 minute to spare, so I'm delighted. Thanks again for the opportunity to speak today.
Thanks, Mira. That was a fantastic overview, and appreciate that. So the next speaker is Ms. Colleen Heffernan, and she's going to speak about lip and tongue ties, the evidence. Ms. Heffernan is a paediatric ENT surgeon at CHI at Temple Street and a UCD clinical lecturer and assistant professor. Thanks, Colleen.
Thanks very much for the opportunity to discuss what I call a Marmite topic. So just a few facts. We know that the prevalence of tongue tie hasn't changed, but the number of frenotomies has increased over the last couple of decades. And this is predominantly in children who have private health insurance and those who are the firstborn in their family. And just a few important studies to highlight. The first is from Chris Hartnick in the Mass Eye and Ear, and he noted that the number of frenotomies he was doing was increasing, and 95% of children who came to him with a tongue tie had a frenotomy. And he decided to change his practice, and instead he sent all these children first to his speech and language therapist who had a special interest in infant feeding. And by doing that, he went from doing frenotomies on 95% of the referrals down to 30%. And I think this is just important because it highlights the fact that most infants who are presenting with feeding problems improve with lactation support, and surgical intervention is not always the best option for them. The next is just a clinical consensus paper that was written by ASCO, CENTAC and the American Academy, because they felt there was a need for some sort of guideline for ENT surgeons because of the topical nature of tongue tie, and most of their opinions would mirror my own. And then this paper is well known to us all. I think we've all quoted in exams. It's the Cochrane review from 2017. They looked at 5 randomized controlled trials, 302 infants under the age of 3 months. And these infants were either randomized frenotomy versus no intervention, frenotomy versus lactation support, or frenotomy versus a sham procedure. And they found that it definitely had a significant improvement on maternal pain, but they didn't have any long-term data to be able to comment on infant weight gain or length of breastfeeding journey. And so a lot of people felt that this wasn't a very useful study, but of course it is, because the number one reason women stop breastfeeding is because of pain. And if a baby isn't feeding well, the mother's at risk of mastitis. And if a mother has to stop breastfeeding early for these reasons, it causes a lot of psychological distress and maternal guilt. So the first controversial area is the posterior tongue tie. I think the reason this is confusing to a lot of surgeons is because it's not a tie of the posterior tongue. It's still very much a tie in the anterior oral cavity. And the first report in the literature was in 2009 about this. And the interesting thing is that since then, there's been very little in the medical literature, which is in complete contrast to social media, where it's a very common topic of discussion. There have been 2 clinical opinions, one from ENT and one of the breastfeeding journals, where they claim that this is an entity that was basically created for financial gain. Another case report, very dubious, an infant with multi-level dysphagia was worked up, no etiology could be found. Then they divided the posterior tongue tie, and then at an interval, everything improved. But for those of us who look after infants with difficult feeding, we know that at an interval, most infant feeding problems do resolve. So this also may not be very relevant. And when people talk about a posterior tongue tie, this is what they speak about. So we all know this is abnormal and this is abnormal. And usually in classification systems, at some stage you should be trending towards the normal. But the feeling people have is that this is very occult, only certain people can diagnose it and find it, and that it causes more trouble than the classical tongue ties. This is an anatomical study that was done as a collaboration between ENT surgeons and anatomists in the US and New Zealand. And they wanted to figure out what exactly the frenulum was. And so it's not a discrete band of tissue. Instead, it's a fold in fascia. So the fascia inserts along the mandible and then blends in with the tongue musculature. And then in the midline, there's a fold of this fascia with the mucosa draped on top. And they're very clear that this is a 3-dimensional dynamic structure that obviously appears different depending on the position of the tongue. It can sometimes include genioglossus if the tongue is extended, but in general, there's no muscular component. So it's not a band or a cord. And of course, everybody does have this midline fold of tissue and the fascia. People who do a lot of tongue tie surgery obviously publish a lot to try and support what they do. And this man is a tongue tie practitioner, as they're called in the States. And he did a study showing that breastfeeding improves after a posterior tongue-tie division. But it's a bit dubious because he enrolled the patients himself. He was the only one who diagnosed them. And the tool he used to assess improvement after the procedure was a bottle with a sensor in it. And yes, all the metrics improved afterwards, but of course, bottle and breastfeeding are completely different skill sets. One is a sucking mechanism and one is more of a massage. So again, this doesn't necessarily mean that dividing the posterior tongue helps. And it's important to say that when they talk about dividing a posterior tongue tie, it's a more invasive procedure where they divide mucosa, fascia, and they advocate dividing into muscle as well. And this is why I presume they like to use laser. This is an important tool. So this is an assessment tool for tongue tie. And the reason it's useful is that it's valid, it's reliable, it's sensitive and specific. And most researchers strongly advocate that this is used in any research and also assessing any infant. And the important thing is that if the infant has a normal function score, it's absolutely irrelevant what the frenulum looks like. And that's important because I think a lot of us treat what we see as opposed to what the actual problem is. And the other thing is that if a functional problem is found, again, surgery is only advocated if the child does not improve with appropriate lactation support and education. So the next controversial thing are lip ties. And so Kotlow was a dentist from New York who first hypothesized that a tight upper lip frenulum may affect breastfeeding. He felt that if the upper lip couldn't flange, then the baby couldn't adequately latch on. And so these type 4, obviously, he claimed was the most serious type. But this classification system was not found to be very reliable. So subsequent researchers have tried to improve this by merging the different types. And this is the classification system that's used in most research studies. And the two most recent papers that have been produced are very similar to each other. They're both from the US, and they enrolled consecutive infants in their local maternity hospitals. And these infants were examined by 2 independent examiners, and their upper lip tie or the frenulum was graded. And the important things here is that first off, the commonest appearance of the upper lip frenulum was a type 2 or 3, with 20% of infants actually having a type 3 frenulum. And the other thing that's important is that there was no correlation between the type of upper lip frenulum they had and breastfeeding outcomes. And actually of note, in this particular study, from Texas, they found that the women who had the best breastfeeding scores were actually those whose infants had a type 3 upper lip frenulum. So now people very much feel that this appearance, this class 3 or the class the class 4 or the type 3 here is actually the normal appearance of an upper lip frenulum in an infant, and surgical intervention is not warranted and also is not going to help. Lots of studies have looked at the upper lip frenulum over time. This is the largest one of 1,285 people, and essentially they all show that the upper lip frenulum regresses as the maxillary alveolus increases in cradiocaudal length. So then parents will say, oh, but if it doesn't affect their feeding, what about their teeth? Is it not going to cause a gap in their teeth? And of course, this is also not the case. So a gap in the central incisors is a very common and normal appearance for children when they have milk teeth. Dividing the frenulum does not prevent this. And when the permanent teeth erupt, particularly the canines, this will usually resolve. And the American, the British and the Australian dental societies all say that an upper lip frenulum should not be divided, either to treat a diasthema or to prevent one. And the only thing that will ultimately treat one if it occurs is orthodontic treatment. And the next thing then is laser. So laser is something that parents really like. And if you read social media, they very much say you need a practitioner who uses laser. It's less painful, there's less bleeding, it's more accurate, they can do a more thorough job. But for us in the surgical profession, it's hard to believe that laser would be better in this situation. We know obviously that there's thermal collateral damage from laser, which there isn't with cold steel. And in a small operating area, this is important. We also know that tissue heals quicker if it's divided with cold steel as opposed to laser. So this is oral mucosa, and a week post-procedure, the epithelium has nearly fully recovered in that divided with scissors or cold steel. And this is important because pain for a feeding infant is relevant. I certainly admitted an infant who needed to be NG temporarily after a laser tongue-tie division, and the presumption it was because of pain. And also that anatomic study that I described, they warned against using laser also, because they said branches of the lingual nerve are intimately related with this fold in the fascia. And a neonate can't tell us if their tongue is insensate after a procedure, but it may be very important because sensation of the tongue allows reflex movements of the musculature. So this was also quite relevant. And all the studies that have been done for tongue tie and showing that frenotomy is beneficial have been done with cold steel. There has been any studies done with laser are studies looking at just laser and not comparing them with anything else. Now, the breastfeeding outcomes are the same, it would seem, between laser and cold steel, and neither require an anaesthetic. But there is a lot of concern about complications. Anecdotally, it seems that bleeding can be worse with laser, and certainly scarring can be worse, and potentially pain also. And then the last thing is speech. So it would make sense that a tongue tie could affect speech, but when you speak to speech and language therapists, they don't agree. So they say that the sounds that should be affected are interdental sounds, lingual alveolar sounds, but you only need to be able to touch the back of the incisors with your tongue to produce these sounds, and people can compensate very well. A systematic review in their literature would say that there's insufficient evidence at present to say that a frenotomy should be performed to improve speech. They do, of course, say that a lot of these studies are hard to interpret because it's often the parents who assess these children post-op as opposed to speech and language therapist. And this is an interesting study from the beautiful Nova Scotia. The children on average were 44 months and they'd all been referred to the tongue tie and concerns for articulation issues. And they were assessed by the what's called the Fristo articulation score. And they were assessed pre and post procedure, and there was actually no improvement. And the speech and language therapists who were involved in this study also said that the articulation issues that parents had noted are actually age appropriate and would have resolved with time or without intervention anyhow. Then just in conclusion, there's a whole range of other topical and controversial issues in tongue tie. People feel it can cause all a range of different issues, and also that there's a whole range of treatments, none of which cause any harm except for financial. But it's just important to be aware of this. And so just in conclusion, frenotomy is not a panacea for everything, but it certainly is a very useful procedure in carefully selected infants and children. Thank you very much.
Colleen, thank you very much. That was a really comprehensive overview of what can be quite challenging in clinical practice. So that was a great talk. Thank you. So next we move on to Ms. Mary Bresnihan, who's going to talk about the exit procedure team approach. Rania, after completing a fellowship in Birmingham Children's Hospital, is currently a consultant paediatric otolaryngologist in CHI Ireland at Crumlin, and she's also associate clinical professor at University College Dublin. Thanks, Rania.
Thank you, Mary. Good morning, everybody. Ladies and gentlemen, honoured guests, it is a privilege to speak to you today about the exit procedure. So the exit procedure, exit is an acronym that stands for ex utero intrapartum treatment. Skarsgård et al. First described this procedure as an operation on placental support and coined the acronym OOPS. And for obvious reasons, that didn't gather favour with the paediatric airway community. So what is it? The exit is defined as a procedure that's performed after partial externalization of the fetus from the uterus whilst maintaining fetal placental circulation. So you can see here in the picture, the baby's head and upper body are delivered, but the torso and the legs are still in the uterus. This allows us to secure the fetal airway in a controlled fashion while maintaining oxygenation. So it converts an emergent, life-threatening and potentially catastrophic situation into an elective and controlled one. But the success of this procedure rests on careful patient selection and meticulous planning within the MDT framework. An exit procedure was originally developed to reverse temporary tracheal occlusion in patients who had undergone fetal surgery for severe congenital diaphragmatic hernias, and that was back in the late 90s. However, the indications have expanded over time, and it's now used whenever difficulty is anticipated in establishing an airway in babies at the time of delivery. So some indications include chaos, thoracic masses, hypoplastic craniofacial syndrome, mediastinal tumors, pleural effusions, and large CCAMs, which are congenital cystic adenomatoid malformations of the lung. Chaos, also known as congenital high airway obstruction, is defined as any complete or partial upper airway obstruction, and it can be caused by a range of things such as a teratoma, lymphangiomas, or mandibular disorders, and rarely laryngeal or tracheal atresias. So a baby for potential exit is usually identified at the 20-week anatomy scan as it happens in Ireland. And at this stage, the obstetrician is alerted to a potentially obstructed airway because they might see a mass there, they might see polyhydramnios. And the obstetrician will then go on to contact a tertiary referral Peds-ENT centre in Crumlin, as well as a fetal medicine specialist centre in Dublin. We will then review the case in an MDT setting to assess the suitability for an exit procedure. So the involved parties usually are ourselves as pediatric ENT surgeons, the obstetricians. You've got the adult and the pediatric anaesthetist, pediatric radiologists, as well as neonatologists. We involve our ENT airway clinical nurse specialists, as well as our ENT theatre clinical nurse managers. We review the radiology and we discuss the important fetal and maternal factors. An MRI and fetal cardiac echo are essential prerequisites when considering the exit. The cardiac echo will tell us if there's any major or lethal cardiac abnormalities, which would be a contraindication to an exit procedure. Sometimes the MRI is done in a tertiary referral, in a referral centre, but when we bring them over to us, we will often repeat the MRI in Crumlin to ensure imaging of the fetus is optimal. The antenatal ultrasound will identify a cervical mass, as well as any indirect signs of airway obstruction, such as polyhydramnios and decreased swallowing. But the MRI will determine the extent of this mass, the size of it, as well as the presence and patency of a larynx and a tracheobronchial tree. So is there an airway to intubate and or trach? The MRI will also determine if there's normal architecture of the brain, the heart, and the lungs. The fetus is tested for common chromosomal abnormalities, and it's of the utmost importance that an exit is not considered where there are lethal or significantly life-threatening anomalies. Similarly, we also look at the mum. So maternal factors to consider are things like fitness for general anesthetic and any other significant comorbidities that may be a contraindication to her having a GA. So the parents are counseled initially by the obstetrician and the neonatal teams in the maternity hospital with regards to the diagnosis of the fetus, the management, and potential future implications. But then from an ENT point of view, we need to talk to the parents with our clinical nurse specialists to talk to them about the exit procedure and potential risks. But we also need to talk to them about the short and long-term morbidities associated with the upper airway obstruction, potential surgery for this, and the likelihood and implications of a long-term tracheostomy. This is a photo representation of the number of people that are usually in the operating theatre on an exit day. You can see there's various teams. All these teams congregate at an arranged time in the largest theatre, and we do a dry run of the procedure with each team leader describing their role. So we'll start with the maternal anaesthetist, then the obstetrician, then the ENT surgeon, and then the neonatologist. We discuss any potential different or difficult scenarios so that we know what everyone is doing. The list of the team members that are essential on the day, you can see there. There are a lot of others involved as well, such as obstetric nurse managers, circulating nurses, etc. This is our current team in Ireland. We have consultants from various CHI hospitals, as well as the 3 maternity hospitals in Dublin, from a obstetrics and neonatology point of view. So the anesthetic itself for an exit procedure is much more complex and quite different to a standard C-section, and it requires careful coordination between the maternal anaesthetist, the obstetrician, and the ENT surgeon. So the basic principles in an exit procedure is you want to protect the placenta, ensure that there's adequate blood flow through the umbilical cord, and you also want to avoid contractions of the uterus. So to achieve these, you need to have a deep plane of anesthesia. And you have profound uterine relaxation, which is in stark contrast to your traditional C-section where you actually want it to contract. So there's a very high risk of maternal hemorrhage. Fetal analgesia and anesthesia are not usually required in a standard C-section, but they would be in an exit procedure. So once we start the procedure, the obstetrician incises the uterus away from the placenta. The baby's head and one arm are delivered, as you can see here. The pediatric anaesthetist will attempt to intubate the baby. If they can't, then the ENT surgeon steps in, and we might try and do it either with a Parsons laryngoscope or a rigid bronchoscope. And if these methods are unsuccessful, then we proceed quickly to an open tracheostomy while the baby is still attached to the maternal circulation. Once we've secured our airway and we're happy that we have a safe airway, then the umbilical cord can be divided and the baby is taken off placental circulation. So in general, the fetal gas exchange can be supported ex utero placental circulation for about 45 to 60 minutes, but there have been some cases in the literature whereby this has been done for up to 2.5 hours. Once we've secured the airway, the baby is transferred with the neonatal transport team to the pediatric ICU in Crumlin. If we've done a tracheostomy, then an ENT surgeon as well as a pediatric anaesthetist will travel with the baby in case we lose the airway. So to illustrate the importance of an MDT and the kind of things that we talk about and discuss, I'm going to talk about a few cases. The first one is a baby that had a large nexus identified at the 20-week anatomy scan. And this showed a large multilocular nexus and severe polyhydramnios, which you can see in the MRI on the right. The baby went on to have a fetal MRI at that stage, at 24 weeks. And this showed that there was indeed a large mixed solid and cystic mass, and it was extending into the upper chest, which you can see here, and it was indenting the heart. At that stage, we couldn't identify a trachea. So we repeated the MRI a few weeks later, which confirmed that the solid and cystic mass was there. It is increasing in size as the baby was growing. And we could identify a larynx. And we could also see that the airway was deviated to the left, and there was a fluid signal in the right and the left main stem bronchi and both lungs, indicating that the baby could swallow fluid and fluid could go past this mass into the airway. Baby had a normal fetal echo, normal karyotyping, and the rest of their anatomy was normal. Thus, at the MDT discussion, we felt that this was a suitable exit candidate. Initially, we planned for the exit at 34 weeks, but at 32 weeks, the obstetrician contacted us saying that the mum had worsening polyhydramnios, baby had a right-sided pleural effusion, and they were worried that mum would go into spontaneous labor. So we pulled the exit forward by 2 weeks and delivered at 32 weeks. Before the exit began, our interventional radiology consultant performed an ultrasound-guided drainage of about 40 mils of fluid from the largest cystic region of the mass to try and decompress it a little bit, and hopefully try and get the trachea to medialize a little bit more. Once the head was delivered, we could see that there was a large cervicomediastinal mass and that the larynx was still deviated. Intubation was attempted, but we couldn't even get a 2.5 endotracheal tube in due to the distorted anatomy. We inserted a Cook ventilating catheter and tried to thread the endotracheal tube over that, but we still couldn't intubate the baby. Thus, we proceeded to a tracheostomy on placental circulation. Once we established the airway, the baby was delivered, umbilical cord was cut, and baby was transferred to the pediatric ICU in Crumlin at 2 hours of life. She then underwent a complete resection of this neck mass, including the thymus, in conjunction with our cardiothoracic colleagues at day 13 of life. The final histology of this was a teratoma derived from the thyroid gland. Our second case, at the 20-week scan, baby showed to have severe retro or micrognathia. The MRI showed that the lungs were very small and perhaps the ribs were a little bit abnormal. There was a bit of fluid in the lungs. The genetic screening for the basic 8 anomalies was normal, but mum had a history of myotonic dystrophy. At that stage, the fetal echo hadn't been done when we were doing the MDT discussion, but due to the maternal risk with a general anesthetic because of her history of myotonic dystrophy, we felt this was not a suitable exit candidate. Baby was delivered as normal and was found to have cerebrocostomandibular syndrome at the time of delivery, so that you couldn't open the jaw at all, and they had severe cardiac abnormalities on echo. The baby was palliated and unfortunately passed away at day 2 of life. Our third case was a baby who was found to have a very large anterior neck mass on the 20-week scan. A fetal MRI confirmed a 10 by 5 by 4.7 centimeter mass extending from the mandible and dipping into the thoracic inlet, and it was going from one mastoid to the other, likely consistent with a teratoma. And although the fetal echo was normal, baby had normal lungs and a normal brain and was otherwise normal karyotype, at MDT discussion, we felt that trachea was not going to be accessible for a tracheostomy if we couldn't intubate the baby. So although this baby was not an exit candidate, it was a candidate for an attended delivery whereby a neonatologist was present at the time of section in order to intubate the baby straight away. Fortunately, baby was successfully intubated and was transferred to Crumlin within a few hours of life. They underwent an MRI scan that day, which you can see a large mass extending from mastoid to mastoid, as I mentioned, and there is no way that you'd be able to cut through that to get to the trachea had the baby not been intubated. We successfully resected this mass on day 2 of life, again in conjunction with our cardiothoracic colleagues, because it was extending into the upper mediastinum. This was found to be, again, a teratoma arising from the thyroid gland, and baby is thriving and doing very well. And our final case is one whereby an MRI detected a large multiloculated cervicofacial cystic lesion. It was extending from the superior orbital level on the left side, consistent with a large lymphatic malformation. A repeat MRI at 33 weeks showed that this was increasing in size and compressing the airway. Otherwise, baby was normal with no other abnormalities, and MDT discussion felt that this was a suitable exit candidate. At the time of exit, laryngoscopy was extremely abnormal, and although we got an endotracheal tube into the airway, we couldn't reliably confirm to say that it was in the trachea because of the anatomical abnormalities. So we performed a tracheostomy on placental circulation. And you can see here by the clinical picture that the tracheostomy is actually coming out from the right side because everything was shifted and deviated over by the lymphangioma. Baby was delivered and brought to Crumlin. We performed an MLB in Crumlin on that day, and it showed extensive anterior invasive tongue microcystic disease, hence the abnormal anatomy. Since then, this young lady has gone on to have some sclerotherapy as well as CO2 laser debulking of the supraglottis and is currently on sirolimus treatment. So in conclusion, technological advances in ultrasound and MRI have improved our ability to diagnose congenital abnormalities in utero. And the exit procedure is relatively new and holds a lot of promise for newborns with airway obstruction. The indications for the procedure seem to be increasing as the safety to the mother and the baby keep improving. And although conceptually this is a straightforward procedure, early MDT planning and careful patient selection is essential for a successful exit procedure. Thank you.
Thanks, Rania. That was fascinating. Wonderful to see the cases that you put through there. So we'll move on to our last speaker. It gives me particular pleasure to introduce Professor Trevor McGill. Professor McGill is actually in Ireland at the moment as he's receiving an honorary fellowship from the RCSI this evening. Professor McGill is Professor Emeritus of the Department of Otolaryngology, Head and Neck Surgery in Harvard Medical School and Boston Children's Hospital, and he was the senior surgeon in the Department of Otolaryngology, Boston Children's Hospital for 40 years. Trevor's going to give us an overview of his career in ENT, and I'm delighted to welcome him to Ireland to do this.
Thank you, Mary, for asking me to share my journey in pediatric otolaryngology and how I ended up in Boston for most of my career. I will also mention some of the people I met along the way and enumerate some of the changes that have changed, that have occurred since Professor Paul O'Neill was a resident here at Boston Children's Hospital. So how did I get here? My initial training in otolaryngology was in London at the Royal National Throat, Nose and Ear Hospital in Golden Square. Here was I, a single guy from Dublin, and my digs were on the top floor of this hospital, not exactly a penthouse suite, but it was about 400 yards from Piccadilly Circus. My one and only a colleague at that stage at the SHO level was one Bill Gibson, who went on to be an otologist at Queen's Square, and also a very respected, internationally respected cochlear implant surgeon at in Sydney, Australia. Following my time at Golden Square, I went to Liverpool, where I spent probably one of the happiest 4 years of my life with colleagues such as Charles Vyse, Kevin Manning, Hugh Burns, Kieran Tobin, Kathy Law, etc. We had a great time here. It was a wonderful clinical experience, and we had also good crack. Here is a photograph of some of us probably at a BACO meeting. On the left is Jerry Leonard, that's David's father, Hugh Burns, Mary Burns, the late Anne, and Kevin Manning, myself, Kate Leonard, and Kieran and Anne Tobin with my wife in the forefront. Following us, there was another generation of Irish otolaryngologists who occupied some important positions in otolaryngology in Ireland. Ray Clark, of course, is a consultant pediatric otolaryngologist in Liverpool, Old Hay. I worked with two outstanding surgeons at Liverpool. One, Mr. Philip Stell, who had an outstanding career as a head and neck surgeon. He was tireless in his pursuit of the optimal therapeutic management of his patient with head and neck surgery. He published extensively, both in English and in the Dutch language. My first paper on laryngeal cancer and the possible exposure to asbestos was published with him in the Lancet. However, it was Mr. Bob Tracy, a consultant otolaryngologist at Old Hay and subsequently at Great Ormond Street, who was responsible for me pursuing a career in pediatric otolaryngology. He had a wealth of experience in dealing with patients with complex airway problems. He was an excellent endoscopist and a father figure to me. He truly wanted me to return to the UK after I finished my fellowship at the Mass Pioneer Infirmary, and was bitterly disappointed that I did not take up that position, consultant position at Great Ormond Street in the early 80s. He had a keen sense of humor, but usually at somebody else's expense. I remember one Friday afternoon, I was anxious to get on the train to go and see a rugby game down in London, and he was doing a typical mastoidectomy, and I was observing, and he would ask me to, McGill, as he moved from the free field to the microscope, please remove my my glasses. McGill, please put on my glasses. I did ask him, of course, when I could clean his glasses, and he said, when you get your fellowship, which we subsequently did here as I with Kieran Tobin. I think that man in the background there has taken a poor view of my long hair. However, in the fourth year of my time in Liverpool, I was a recipient of a Fogarty International Scholarship Fellowship, where I could spend 2 years at Massachusetts Eye and Ear Infirmary. The first year was spent with Dr. Hall Shutning, studying temporal bone histopathology, and the second year was a clinical year with Hall Shutnick in otology and Bill Montgomery in head and neck surgery. During my second year there, Dr. Shutnick asked me to kind of go over to Children's Hospital, where Judah Falkland was in dire need of a pediatric otolaryngologist. So Judah, who was the father of angiogenesis, took me on a tour of the hospital and mentioned enthusiastically, I must show you this new microscope we got for you guys down in the emergency room. After seeing it and reviewing it, I didn't have the heart to tell him that this indeed was a slit lamp used exclusively by ophthalmologists. However, after our hour's conversation, he said, when can you start? This was in April, and he said, why not tonight? And that's how one got a consultant position in 1976. When I arrived at Children's Hospital in 1976, Dr. Stuart Strong sent a Dr. Gerald Healy over to Children's Hospital to look after the Boston University students then. And we worked together for the ensuing 35 years. When we went to hospital, sorry, when we started the Children's Hospital, we soon realized that the anesthesia department looked after all the airway problems, and all the head and neck problems, including tracheostomies, were performed by the general surgeons. Well, on demonstrating our expertise in pediatric otolaryngology, particularly endoscopy, we soon became the service of choice to deal with all head and neck problems and all airway problems. Children's Hospital is now a very busy place, 400 beds and 25% of ICU. With the addition of a new wing in June of 2022, there will be 240 beds, 240 ICU beds, and one includes the ICU beds in the adjoining hospitals, Peter and Brigham and the Beth Israel Hospital. We are affiliated with the contiguous Dana-Farber, Brigham, and the Beth Israel Hospital. Over the past number of decades, we have sprung from just Jerry and I, just two attendings, one resident, one half secretary, to now we have 16 pediatric otolaryngologists and a supporting staff of 120. We've also developed these various programs in which difficult problems are evaluated in a multidisciplinary fashion. Like the voice and velopharyngeal dysfunction program is where one is a pediatric otolaryngologist, a plastic surgeon, and a speech therapist evaluate the dysfunction, the voice dysfunction. As many of you know, we have a program in place whereby registrars from the Irish Training Program in Otolaryngology come to us for 6 months. On the left here was Paul Lennon, who was a registrar with us at the time, myself in the center, and the very young attending, Karen Walters, who in fact is helping me here with this virtual meeting today, and of course, Stephen Kieran, who was the fellow at that time. It was Stephen who quoted this, that you need at least one syndrome to get in the door of Children's Hospital. Some changes have been the role of a physician assistant. Who are they? Physician assistants are medical practitioners who work under the guidance of a surgeon. They are trained to deliver a variety of important patient-centered roles, including patient history, a physical examination, making a diagnosis, evaluating test results, performing preoperative and post-operative education. And they're also trained to perform minor procedures such as here, a flexible endoscopy, flexible removing foreign bodies from the nose, perhaps to the external canal, and indeed changing tracheostomy tubes. Another addition which has been very important in the management of very busy service, this is the chef de service, or the consultant of the week, the COS system. This program was created in 2008 to fulfill the demands of a very busy clinical and an educational service, high volume and high intensity. This requires one pediatric attending surgeon who rotates on a weekly basis, and they cover the inpatient service from 6 a.m. in the morning to 6 p.m. in the evening with a personal sign-off to the evening staff. He or she is assisted by a fellow, one resident, two inpatient physicians. So they see all the emergency admissions. They are responsible for all the inpatient consultations, emergency room consultations, and all perform surgical procedures which are scheduled with other disciplines, such as when we have a cleft palate repair. Obviously, that infant requires bilateral laryngotomy and insertion of grommets, and this will be performed by the chef de service. In addition, they also perform consultations with the ICU and two adjoining hospitals, the Brigham Hospital and Beth Israel Hospital. This system is very good from an educational point of view, where these residents and fellows and medical students are exposed to the same physician for the whole, same surgeon for the whole week. It also ensures a continuity of care for the whole week, where that one pediatric otolaryngologist is in charge of all the service and all the patients for that particular week. There is some difference between the European and the North American work day. Ward rounds are at 6 a.m. in the morning, conferences start at 6 a.m. We had a professor, Tony Narula, was a visiting professor not too long ago, and he was aghast at the very fact that we'd have to give a lecture at 6 a.m. in the morning, 7 a.m. in the morning. So we advised him to stay on Greenwich Mean Time, which he did, and he was delighted to give it therefore at 11 a.m. However, evening activities are certainly curtailed. They probably start about 6 o'clock and end about 8 p.m. The promotion criteria at Harvard Medical School is forever changing and is forever changing and rigorous. First, one has to select their area of expertise. Usually for a surgeon, it's going to be in the center here, the clinical expertise and innovation, as opposed to basic research. All candidates are evaluated for their teaching capabilities and educational activities at Harvard Medical School and associated hospitals. One passes from starts as an instructor, then an assistant professor, an associate professor, and then a full professor. To attain the rank of full professor, one needs a sustained national, if not international, reputation as an innovator in pediatric otolaryngology, and very few attain this level. It is your rank at Harvard Medical School is tremendously important. Why? Because it determines your salary. So if you don't publish and you stay at the level of an instructor, your salary will probably stay at that level, apart from some minimal cost of living living increase. So I will leave you with some advice to some young surgeons. One should garner good relationship with other disciplines, particularly in pediatric otolaryngology. You cannot treat patients without good relationship with pediatricians, infectious disease personnel, and anesthetists. Develop a good relationship with administration and maintain respect for each other. Too often, nose and throat surgeons will come in the front door of a hospital, do what they had to do, and leave by the back door. When you need it, ask advice from more experienced colleagues. Be always available and supportive of ancillary staff, because they are your ambassadors. When you have difficult clinical problems, please communicate in person rather than via email, Instagram, text, etc. If you have a patient that needs to go to the operating within the next hour, please talk to the anesthetist in person and forever try to raise the profile of otolaryngology with your colleagues in other disciplines. Be humble, but confident in dealing with patients. And to quote my dear colleague, Dr. Gerald Healy, patients don't care how much you know unless they know how much you care. And I will leave you with, to paraphrase the advice of the late Dr. Hardy Hendren, Chief of Pediatric Surgery at Children's Hospital, who recommended that surgery requires more than dexterity. It requires concern for your patients, honesty with your judgment, a willingness to ask for help when needed, and free admission when one has erred in judgment, diagnosis, or treatment, i.e. surgery. Thank you very much. Irish Otolaryngology is in good shape. Here we have the esteemed head and neck surgeon, Taig O'Dwyer, who's just recently captain of Port Monarch. We have Laura Vianney, then the next president of the Royal College of Surgeons. We have John Russell, the recent president of the European Pediatric Society, and a good self. I think I got a medal. Thank you much.
Thank you, Professor McGill. That was really interesting and entertaining, and fascinating to see the journey over that period of time and how things have changed. I particularly loved your summary and emphasis on teamwork, and I think that's one thing that all the talks highlight in pediatric ENT in particular, the importance of multidisciplinary teamwork and ability to work with colleagues. So thank you very much to all our speakers today. We really appreciate the time and effort it has taken to both prepare your talks and to be here, particularly those that are up in the middle of the night or have had to travel long distances. And we'd just like to open questions to the floor, really. If you have any questions, please put them up in the live Q&A section or the discussion forum, and then we can put them to our distinguished panel. Maybe I could start with a question to Mira, maybe. You mentioned your firstly with sleep disordered breathing and to have a low threshold for an abdominal tonsillectomy. How low a threshold do you have in clinical practice?
I think it's really difficult, Mary, to answer that question. I think it very much varies from child to child. If I was taking a child for an abdominal tonsillectomy, it's really important. I think the key to all of this is open communication with parents and very real expectation management. I think that really is the key. If they've got clearly obstructive tonsils and a clear history of sleep disturbance, then it makes the decision quite easy. But if they've got relatively non-obstructive tonsils, it becomes more difficult. And it's important to say to parents that it's impossible to tell whether the tonsils nads are larger or relatively small to begin with, what functional difference that will make to the child's upper airway. If I do take the child to theatre for an abdominal tonsillectomy, something I do at the same time as it dies. So I do a drug-induced sleep endoscopy at the same time, and that will show me whether or not there's hypotonic laryngopharynx, for example, or prolapse of the tongue base, so that post-operatively we can say to parents, look, these are the other issues. We'll see what the child is like after, and then we'll know how we can help further if help is indeed required.
Very good, thank you very much.
No worries.
Any of the other members of the panel have anything that you could add to that? This is obviously a common clinical conundrum.
Mary, I don't feel the need to add to it, but I do have another question for Mira. You know, over here, we're discussing the Inspire device like it's going to be the second coming for neurodevelopmentally impaired children as far as sleep is concerned, and we eagerly await the results of the Down syndrome trial over here. But I don't know, do you in the NHS have any experience with the Inspire device at all, and has it been promising?
We haven't, we're so underfunded, Dave. That's only a pipe dream for us at the moment, the Inspire device. I mean, I'm afraid for children who are going to have some form of NIV, for us, it's really high flow oxygen, CPAP or BiPAP. Do you find, Dave, the children are more tolerant of Inspire than they are with those other modalities?
We've had no experience with it because it still is only available on trial, and we're not one of the trial centers. Speaking more broadly, I tend to do more tongue-based suspension than I do tongue-based reduction, just because I've had experiences with bleeding from the posterior tongue base that have put me off the procedure. But I do find that when you do tongue-based surgery in these patients, like often happens when you start adjusting multi-level obstruction in the airway, that they are able to use a lower pressure CPAP or a lower flow, high flow oxygen, and that it does make tolerating non-invasive support easier for them.
That's a really important point, actually. It's exactly that. It's not necessarily that they may not need an IV, it's that the pressures are lower and they might be better tolerated, or you might take a child from the need for CPAP to being able to cope with, for example, wafting high flow or something along those lines, you know, from a bad to a slightly better situation, if that makes sense.
And David, I asked you a question about your patient with a posterior laryngeal cleft with obviously after repair, significant tracheomalacia. And this is a very, very frustrating problem, as you all know. Was there any thought about pexing the trachea to the prevertebral fascia, as you probably kind of have some of your thoracic surgeons, those people who deal with TEF on a regular basis?
So the one of the details of that patient that I didn't include in the presentation for limitations of time is he had fascinating thoracic and cervical vascular anatomy. And so many vessels in many unexpected places. And so the thoracic surgeons were not excited about opening his chest whatsoever. Now, we do have a new thoracic surgeon here that will do PEXIs for us minimally invasively. And so that may be something that's worth exploring. But he's doing so well at the moment that there certainly is an element of it. If it's not broken, let's not try and fix it for the moment.
May I ask you another question? You talked about that you did not cover the sort of neuroanatomy, et cetera, in your embryology mini talk. You know, sometimes we have congenital hemangiomas. Why is it just confined to the subglottic space?
You know, I think probably there's some component of anatomy there with the limitations created by the natural fascial planes and the conus and other structures. But you know, I can't give you a great answer to that.
All right. Can I ask Colleen? Colleen, do you believe in this posterior tongue tie? Unfortunately, in North America, we have very bad experience with this. It's been taken up by our dental colleagues, which are using a laser extensively. Unfortunately, I can say it now, totally for reimbursement reasons. First of all, do you believe it exists? And if you do, what functional result?
So no, I mean, I agree with that too. I think as I say, what people describe as a posterior tongue tie very much looks like normality.
Yes.
I think if you put in a grooved retractor or two fingers and pull up the tongue sufficiently, of course you're going to feel a band of tissue. And that's where the functional assessment is really, really important. So that there is definitely a problem, and that the problem isn't resolving with education and support. We know that we've lost 4 generations of breastfeeding experience. So a lot of people are desperately trying to throw money at a problem. And unfortunately, they're often going to providers who obviously you know, the only option they can offer you is surgery, and so they're going to do that. I think the laser is quite scary because some of the divisions they do are quite extensive, and we have seen problems with floor mouth scarring, with bleeding. Like when I was in Boston, we had a 2-week-old admitted to ICU and transfused after having a laser division of a tongue tie. So I think laser does seem like an overly aggressive tool, and I also think yes, whatever about dividing mucosa and fascia in a baby who it would seem it would benefit, and based on an assessment tool, that's something. But when you start dividing into muscle, yeah, I think that's quite a scary thing. But I think the reason it's important to talk about it is just that it's so topical amongst parents, you know, and yeah, but I don't believe in it.
Well, good.
Yeah, I was going to ask you the exact same question, actually. And you're right, you get a referral from lactation consultants, public health nurses in particular, about division of a tongue tie. So do you feel that even there could be a sort of like it's the equivalent of maybe a grade 1, and there might be a bit of tightness at the back of the tongue? Would you think there's any kind of role for that? When they do obviously they are having breastfeeding problems, that, you know, if you saw an obvious tongue tie, you would divide it.
Yeah, so I think, I mean, if there's problems, and if there's maternal pain, and if there's something that is reasonable to divide with cold steel in a clinic setting, yes, I will do it. But certainly, you know, and obviously the idea of dividing something with laser is quite exciting, you know, it's a nice procedure. But I think once you're going down that route, I think part of the reason people use that is because they do encounter a lot of bleeding, and that's because they're probably going too far. But yes, I mean, if it's amenable to cold steel dissection or division, definitely I would do it. But I always make sure that the mums are linked in with some sort of a support system. And I'm lucky because our ENT CNS spends a lot of time with the mums afterwards. She's a breastfeeding advocate, spends a lot of time with them, and she rings them a day or two later again. So that's probably the most important part of the clinic.
Yeah, that's an interesting part of a trial, just to give the support without the actual procedure in some of them, for sure. Yeah. Thanks, Colleen. Rania, I loved that picture of the number of staff in the theatre for your exit procedure, and I think that's possibly, looking at it and from a human factors perspective, that would give me palpitations. I know you've got it broken into 3 teams, but is there one overriding person in charge? You know, because you know, when you've got 3 different groups or 4 different groups of consultants with different interests, sometimes there can be a bit of conflict there.
Yeah, it's funny when you're actually doing it on the day, you're very much zoned in on what you're doing. So we're very much focused on the airway, just like the obstetrician is very much focused on the mum and the uterus. So there's no kind of clash in that way, and it seems like there's a lot of people, but everybody knows their role. And because you go through the dry run at the start, you know, everybody, it's kind of a seamless transition. You know that when you have to take over from the obstetrician, they're constantly monitoring the baby. They've got the echo on the baby at all times, checking that they're okay while you're doing your bit. So I don't think so. And it seems overwhelming when you get there, but genuinely when you're doing what you need to be doing, you're in the zone and you're unaware that there's 20, 25 other people in the room with you.
Do you think there's, in terms of the future of an exit procedure, do you think beyond just securing an airway, there is potential for other options, more definitive treatments? Given that you're operating them on them that day as well?
So I think for kind of pedunculated teratomas or actinates or something like that, there are cases in the literature where you've resected it at the time of the exit as opposed to tracheing or intubating the baby. So you could do that for kind of smaller lesions. But, you know, again, it's you would have planned that ahead of time. And I think for us, it's very much securing the airway. But yeah, there is scope for expanding for sure.
So Rania, may I ask you a question about the logistics? Here at mine in Dublin, as far as I remember, there are 2 pediatric hospitals and 3 obstetrical hospitals. So what happens? Do you have to take the day off and travel to Rotunda for the day? Is that it?
That's exactly it. There's a lot of logistics, so it's more than just kind of the MDT and discussing the patients themselves. It's organizing all the different teams, and whichever maternity hospital the mum has been referred to, if she's based outside of Dublin, that's where we go to. They give us the biggest theatre there. We go in about 5 taxis from Crumlin with, you know, our theatre staff, all our equipment, everything. We take our own everything down to the bipolar machine, because we've had experience at one where theirs wasn't working. So so yes, it is a bit of a logistical issue, but everything is planned. And obviously the more you do, the more you kind of get into a routine of a checklist that needs to be done.
Well, so the new hospital in St. James, that new pediatric hospital, is that going to have an obstetrical? And
that was the original plan, I think, wasn't it, that we were going to be tri-location with everything there? But I think due to budget issues, I don't think maternity are going to be there in the first instance, unfortunately.
Already? Oh, I see. Yeah. Excuse me for a moment.
And I was fascinated, actually, speaking of the new hospital, I was fascinated at the 193 ICU beds in Boston. How many are going to be in the new children's hospital?
I think that there's going to be over 50, I think near 60 is my understanding. But again, it's ever evolving and ever changing, because there's going to be the separate kind of cardiac ICU as we have in Crumlin, as well as the kind of general ICU.
Okay, very good. Okay. I wonder, Paul, have you any questions, or will we open the questions up to the floor at this stage, up to our delegates? Anyone online? If you want to raise your hand, we could if anyone has any questions for any of our panelists. Actually, I see it's 10:30. Do you think the session's been stopped at this stage?
Yeah, I think we're approaching the final few seconds.
Well, at this point then, I'd like to really give my sincere thanks on behalf of myself and Paul to all of our speakers. It was a really entertaining morning, fascinating, really fascinating. And there's such a difference between adult ENT and pediatrics, and even the world is different. Obviously, I'm in a bit of both, but for a lot of people, they're just an adult, and it's just really interesting to see all your different approaches from around the world. And thank you so much for your time in preparing the talks and delivering them this morning. On behalf of everybody who listened and indeed ourselves, thank you very much.
You can go back to bed now, David. Take care. Bye.
Thanks, everyone.
Thanks, everyone. Bye-bye.
Thank you, and enjoy your evening tomorrow, Trevor.
Thank you.
Bye.
Thank you. Right. Thanks very much.